Today we're going to talk about the same main topics as last time. For part 2 for pregnancy, here are the topics. So we're going to go into the stages of labor, managing labor pain a little bit, medical interventions and decision making, and informed consent. And here are the topics for postpartum, some bladder and bowel health, some symptom management for both urinary and fecal symptoms. And Sarah's going to wrap us up with pediatrics on bowel health, constipation, and how pelvic therapy can help. So for stages of labor during pregnancy, there are 4 if you count the afterbirth when you're doing skin to skin. The first stage involves pre-labor, early labor, active labor, and the transition into second labor. And the second stage of labor is basically the pushing phase. And the third would be the birth of the placenta. So going through pre versus early labor, that's when you kind of have the false labor or the contractions that aren't necessarily consistent or progressing, but they're happening. That can be a week before you actually go into labor. And then you have early labor, which is when you start to feel them a little closer together. And active is when they get real close together and they intensify. And that transition is the shortest but the toughest phase of the first stage, where you're getting ready to push. So those are the main ones. I have this in here because I really like this image of how the uterus contracts and how that contributes to dilation of the cervix, which is at the bottom. So you have, these are not the 3 stages. These are the pregnant uterus, not in labor, followed by stage 1 and then stage 2 labor. So stage 1 and stage 2, you're working towards that full dilation of the cervix at 10 centimeters. But notice at the top of the uterus or the fundus, the active segment of the uterus is what's contracting downwards. So a lot of the contractions will create a lot of pressure, and you'll slowly start to feel that descent as the baby drops into the pelvis as you progress through labor. So the goal of stage 1 and stage 2 is to get to that full dilation. And then stage 3 would be to birth the placenta after the baby's born. All right. Okay, so everybody's question about pregnancy and labor is pain. So how do I manage pain? Is it going to hurt? How bad is it going to hurt? What can I do for that? The biggest thing that I want to make sure everybody understands is that pain is different than suffering. So pain is defined as an unpleasant sensation and overall experience. It may or may not be physical, because obviously we have some certain things like emotional pain, such as grief and loss. And then suffering is a little different, because that's more of a distressing psychological state, and that may or may not be associated with pain. So pain and suffering, it's kind of like a Venn diagram where there's some overlap, but they're not necessarily the same exact thing, and they're not mutually exclusive. So when you think of labor, we'll go into causes of labor pain. There are definite ways to help mitigate the pain itself, but a lot of that is related to minimizing the amount of suffering, so of the overall experience. And then we have that fun scale at the bottom that we always tell people to rate their pain with, and they're kind of like, I don't know, been there for so long, or I don't know, I'm used to it, it's a 2. So somebody's 2, maybe somebody's 10, and vice versa. So everybody's perception and understanding of pain is a little different. So with labor, most of the pain comes from contractions. Obviously, those can be very intense. You saw how thick the uterus got as you progress through labor. And that causes a temporary decrease in oxygen available to the muscles. So that stiffness, that tension really creates a lot of pressure, and it causes stretching on the tissues of the body. So as the baby descends through the birth canal and through the pelvis in general, places a lot of pressure on the rectum, the pelvic floor muscles, the ligaments, the joints, and the nerves. And you commonly hear what's called the ring of fire, which is one of the pelvic floor muscles that has to stretch a ton during labor. And you can see that in those bottom photos. So they kind of make a sling. So that's part of the levator ani muscle group in the pelvic floor. And as the baby's head passes through, that stretches, I believe it was up to 330 times its original length, based on a computer simulation of a 9 centimeter head. So it stretches a ton. And then some other causes of pain during labor can be emotions. So stress and fear and anxiety can all intensify the pain that's already there, and that can contribute to some suffering. So that's definitely part of it. And then considering any medical interventions that may have taken place. So if you have an IV line or a catheter, if you've had an epidural, some of those puncture sites can become very irritating or painful depending on their placement. So that can be another source of pain during labor. So to manage the pain, it's really important to understand how pain works, because pain actually doesn't get perceived until it gets to the brain. So that's why certain people can do crazy things like swallow swords and walk on hot coals, because it's once the signal reaches the brain that the brain decides that it's painful. So the way that that works is it's carried through the nervous system. So our nervous system is our nerves and our brain and our spinal cord. It's like a freeway that carries signals from all over our body and from our environment. And our brain takes that information and decides what we're going to do as a response. So when you think of the nervous system, you think of fight or flight, or sometimes freeze. And then you have also rest and digest, which is when we are more in a relaxed state, when we can digest food and empty our bowels and our bladder and sleep. So they work in tandem, and there's a balance between the two. So I like to give different examples of how this affects labor, because again, with the labor pains, it's kind of inevitable because the uterus is doing some pretty intense things, and that process is very demanding on the body. But it doesn't necessarily mean that there's tissue damage or that there's any danger. So when your brain perceives danger or a threat through pain, then you can trigger that fight or flight response, and that can also intensify the pain. So some examples like a stub toe I give, because a stub toe, sure, it can hurt a ton, but you kind of saw it happen and you know what you did, and it kind of hurts for a little bit, and you rub it and it goes away. So it's a little easier to process. A gunshot or like a stabbing wound, you sometimes hear people that say they didn't even feel it because of all the adrenaline around that type of injury or trauma, versus a toothache, which you can't see at all the physical damage, but it's almost like as soon as you make the appointment to go to the dentist, the pain disappears. And usually that's because it's associated with a lot of inconvenience. I have to take off work, I have to drive to the dentist, I need somebody to take me home from the dentist, and then I need pain medication. And there's all this stuff that goes into addressing that can cause suffering, but not necessarily change what's happening physically at the level of pain. And then you have amputees who don't have a limb anymore, or even an organ, because I know some research has showed phantom limb or phantom organ pain with like a mastectomy or a hysterectomy. You can have pain in areas of the body that aren't there anymore, because the brain still remembers that that body part was there and it has memories of that area. So pain and suffering, again, they're not the same, but there's a reason why they're so intertwined, because everything goes through the nervous system. So this is going to come in really handy when we talk about how to relax and do pushing strategies next week too. So again, going back to the uterus, I like to tell people pain is a little easier to digest when it has a purpose. And again, pain doesn't always mean that there is something structurally wrong or something being damaged or something being injured. So each contraction brings everybody closer to baby, brings baby closer to the world. And on the other hand, you can feed into the process of what's called the fear, tension, pain cycle, which is when you have some pain from the stretching or the pressure or the contraction, and then there's a fear that, how long is this going to last, and what can I do? And there's almost an automatic response to tense muscles and, almost reflexively, and that tension creates more pain. So it feeds into the nervous system in the opposite way, where you can kind of make pain more intense than it really is because of that fear and that tension. So sometimes going back to what is the purpose of this helps to remind yourself, if you are pregnant or in labor, that there's a purpose for all of this. So it kind of calms the nervous system a little bit to remind yourself of that. So I just described this, but contractions are designed the way that they are, and they progress in the pattern that they do for a reason. So again, it's to dilate the cervix and then eventually push the baby out. And the pressure and the stretching are necessary for the baby to make their way out. So pain is kind of inevitable with labor, but it's not always a sign of harm or damage. And again, remembering that it has a purpose makes it a little bit more manageable. And some of those management strategies include relaxation, breathing techniques, comfort measures. So sometimes people like heat, some like cold, and then support to help decrease the perception of pain. So basically, calming the nervous system helps progress labor, because that's what allows oxytocin to flow freely. And so in that diagram on the side, you see that as the baby drops down to initiate labor, the cervix starts to stretch and hopefully dilate, which that stretch in the cervix stimulates oxytocin to be released. And that causes more uterine contractions to occur, which pushes the baby further down into the cervix, which causes more cervical stretch. So you have this cycle happening for a reason. It's just really long sometimes, and it's really intense. So that's where you want to go back to, is understanding that this has a physiological purpose. So lastly, pain is driven by perception, and it's influenced by past experiences and memories. So if you have, maybe this isn't your first rodeo, maybe you've had a baby before and maybe it didn't go so well. And then maybe the expectation is a little lowered or higher if this is your first pregnancy. So everybody's a little bit different. So management of pain has to address all of those things, not just the physical musculoskeletal system. So this includes physical support. So massage is very helpful. Hip squeezes, if you've seen that in birth videos. Different birthing positions are definitely helpful depending on everybody's anatomy and what they prefer, and we'll go over that next week. And hydrotherapy, meaning hot and cold, also helps. Emotionally, you can use words of affirmation. Hopefully a partner can be there to guide you and coach you through that. Some people like to hire a doula, which I highly recommend. They're great. And then there's also environmental support, which includes kind of taking account what's going on around you. So if you're in a hospital facility, maybe dimming the lights can help, quieting the room, playing some music. I always suggest to patients to bring something that smells like home. So bring your own pillowcases, bring your own blankets, because that really also helps with the stress of everything and getting your nervous system to calm down, because it'll feel and smell and look familiar. And then you have medical management, which we're going to get into in a little bit, including epidurals and pain medications that are available. But the bottom line is, to make pain manageable, the nervous system has to feel safe and suffering has to be minimized. So however that works for you, that's part of the process of preparing for birth, is to figure out what positions you like and what breathing techniques you like and all of that. So next week, we'll definitely go over breathing, relaxation, birthing positions, and pushing. So keep that in mind. But pain management has to affect the whole nervous system. So medical interventions are defined as anything that does not occur on its own. So this includes IV fluids, fetal monitoring, induction, pain management, medications, etc. So just as a disclaimer, interventions are not bad. Some are necessary and some are needed. And they can be life-saving depending on the situation, and some are optional. So it really is important to understand which options are out there, and specifically what options are available at your facility that you choose to give birth in, and to consider the potential risks and the benefits of all of them, so that when you're in that moment, you're not having to make a decision based on limited information. So again, not all bad, you just want to know what you're getting into. So the first one we're going to talk about is monitoring. So I have some examples here of fetal monitoring. You can see the external monitor, that's the EFM, and that's on the top left corner where they strap something to your belly. Then you have internal monitors, which you can see below that, where it's attached to the baby's head. And that yellow little wire thing is actually a intrauterine pressure catheter. So that measures the strength of uterine contractions. So that's different than a tachometer, which is also monitoring uterine contractions. And then on the right side, you have the Doppler, which is an ultrasound type of technology where you can externally check the baby's heart rate intermittently. So there's different options, and depending on your facility, you want to know what options are available, because they all carry their own risks and benefits. So whether you want to be strapped to something and you want them continuously monitoring you, which can sometimes lead to more interventions because they're constantly watching the heart rate, and can misinterpret, a change in position as a drop in baby's heart rate, and things can get kind of haywire and chaotic, versus something intermittent like the Doppler every hour, where they come in and place the monitor on your belly. And then you have tools that help with extraction. So Linda talked about episiotomies last week, which is when they make that incision at the perineal body. And so that's something that is sometimes necessary when you're using things like forceps or a vacuum. So that creates more space to get those tools in there. Hopefully you don't need these, but sometimes under an emergent situation where maybe the baby's in a little bit of distress and they need to get the baby out quicker, they may need to use some of these tools, and episiotomy would help place that a little bit more accurately. Otherwise, episiotomies are not recommended. And then the indications of all these on the pelvic floor is, depending on what interventions you have implemented during your labor, that can limit your mobility and your ability to use different comfort measures. So imagine being wired to a machine and not being able to hop in a tub or a shower or use the restroom freely. And then they may prolong labor because of that. So just some things to consider. And then the epidural. So I have an image here because I think a lot of people don't understand what getting an epidural looks like. And it's a very long, thin needle that goes into the spinal column. So you can see that on the right. What that requires is for the person to be very still and in a kind of hunched position. So this person's sitting, but some people do them, some radiologists, anesthesiologists do them with the patient lying down. So it does take 30, 40 minutes depending on, you know, the person. And if your contractions are really close together, that can be very difficult to hold still, but you need to because you can tell it's going into the spinal column. So you don't want to puncture anything that you don't mean to. And then with this, your blood pressure is monitored every 15 minutes. So that can be a little annoying to some people who want to rest during their labor. But depending on your facility, they may have a walking epidural available, which means that you don't get completely numb from the waist down and you can still move around a little bit. It may or may not stop the pain completely. Each facility doses it differently, so that's a conversation to have with your OBGYN. But it is a great intervention for some people, and they'll say that it saved them and they loved it. Some people didn't work so well, or it was really irritating at the puncture site. So just some things to consider. The implications of this on the pelvic floor is that, again, if it's not a walking epidural, then you would be limited in your ability to move around and use different birth positions. And it may limit your ability to push effectively if you do go completely numb from the waist down. So it's also associated with prolonged labor and sometimes an increased risk of C-section. So again, things to consider. Everybody's a little different, but it can be very comforting to have this. And if you're the type of person who knows you don't do well with pain, then you want to definitely consider it and do some research on it. I think the last one I have here is Pitocin. So Pitocin is commonly used for induction of labor. So it's administered through an IV, and it will require multiple forms of monitoring, and that includes for you and the baby. It may also limit your ability to move, eat, and drink if eating and drinking is allowed at your labor, but it does also help to control bleeding after birth. So Pitocin is commonly administered after the baby's born to help clear some of that, or to help minimize some of that bleeding after baby's out. Implications for the pelvic floor include that it typically leads to more interventions because obviously there's more monitoring that has to go on. And because it brings on a hard and fast labor, the contractions are a lot more powerful, and that can make labor more challenging because they no longer follow that gradual progression of starting a little shorter and further apart and then getting more intense and closer together. It's kind of just depending on the dosage and depending on your physiology, how it affects you, it can make labor a lot more difficult. So pain can be a little bit more challenging to deal with Pitocin. I should also add that with the epidural, you will be catheterized. So that's when they put a little tube, a very flexible tube in the urethra to constantly drain the bladder. So that's required for any medical procedure or surgery, but because the epidural takes away your bladder control, they need to make sure you're not retaining urine during that time. So when Linda talks about postpartum urinary symptoms, sometimes the catheter can have some implications and some contributions to that. So keep that in mind. All right. For cesarean sections, I really like this picture because that little baby looks so grumpy. But Linda talked a little bit about C-sections and how that affects postpartum. But just to give you a general understanding, they are a medical procedure. They're a surgery, so they're performed in the OR, not in the delivery room. They require pre-op preparation and anesthesia. And the implications on the pelvic floor include, if it depends on if it was an emergency and if it was just from prolonged pushing that they decided to do the C-section because it's been so many hours and, you know, baby's in distress, depending on what the indications were for the C-section. If you had labored already or attempted pushing, you can still end up with a couple of different pelvic floor symptoms afterwards. And the healing process is longer because of how the abdominal wall has to heal from that. And changing the abdominal muscle tone and strength and having to recover there definitely changes the demand on the pelvic floor muscles. So there can be some implications for that. And lastly, the scar tissue that forms, which Linda already talked about last week, it's right above the bladder, really low in the bikini line, and it's the formation of that can cause some adhesions around the internal organs, so including the bladder, which can affect bladder emptying, bladder filling, and bowel movements as well. So Once again, I just wanted to circle back to pain management because the purpose of all of those interventions are sometimes to make pain more bearable. But pain can be bearable if you understand what's happening, because the side effect of a lot of those medical interventions is that the natural pattern and progression of labor changes, and it can be a lot more challenging. So they can help, but they can also create a disconnect between what your body is doing and what your sense of control is with that, especially when it comes to pushing, which we'll talk about next week. And then going back to that fear, pain, tension, or fear, tension, pain cycle, the side effects of different interventions can make labor more uncomfortable and limit your movement. And if you're uncomfortable, you tense up more. And then if you tense up more, oxytocin can't flow freely. Maybe you have more stress hormones in your body. And that can contribute to more suffering. So again, going back to pain versus suffering, thinking about if the goal is to just completely get rid of pain, it's not always guaranteed with interventions, but it can definitely make you more comfortable, but not without some consequences. So understanding and choosing what's right for you and understanding how you perceive and move through pain is going to be very helpful. All right. So the last thing I want to talk about is decision making. So informed consent is huge for all those medical interventions and with all of the labor process in the hospital, especially with everything going on with the virus. So a lot of things are changing. So definitely call your hospital if you're pregnant and expecting to see what their policies are and how those things are changing. And advice that I got from a local doula group was that you should call really every week, multiple times a week, because they're constantly changing the regulations. But anyways, informed consent is defined as the process of communication between a patient and a physician that results in the patient's authorization or agreement to undergo a specific medical intervention. So this requires a few things, which we'll talk about, but ideally it would end up with conscious agreement, which is the act of making a decision based on your inner listening and your intuition. So a decision that's aligned with what you feel that you need, that you make within yourself, given proper information from your practitioner. So what's required of informed consent includes what intervention is being offered and what it would involve. So if it was an epidural, do you want to get an epidural right now? Well, what does that mean? Oh, you're going to have to lay down for 45 minutes and they're going to puncture your spinal canal and insert a needle, and then we're going to hook you up to an IV, and then we're going to put a catheter in, right? It's important to know all those things because it affects how you're going to labor. And then knowing the associated risks and benefits of the intervention that they are proposing to you, as well as what are your alternative options and the risk and benefits of those. And one of the alternatives, usually under normality, meaning there's no emergency, is doing nothing, right? Oh, you want some Pitocin to speed up the labor contractions? Whereas, oh, what are my other options? Well, we could just not do that. So depending on how you want to approach your labor, it's good to understand how to go about giving somebody informed consent and knowing what questions to ask so that you can make the best decision for you. Because again, unless there's an emergency, the best course of labor is it knows what to do. Your body kind of knows what to do. So depending on what your priorities are, so if it's pain management or if it's not pain management and it's you want to move around and be comfortable, understanding how this process works will help you communicate with your staff when you get to that point. Informed consent should not be, it's not a signed form or a document, it's a process of communication, and it shouldn't be the result of coercion or threat. So if, you gotta watch people's language. If they say, oh, well, baby looks like, baby's kind of big, we should consider, just doing a C-section. Right? You need to ask, well, why do I need that? What are the risks? What are the benefits? And what's the alternative? And what happens if I do nothing, if I don't do that? So I think this is a very important slide for a lot of people to really feel like they're their own advocate. And the purpose isn't to make anybody defiant to medicine or defiant towards physicians or their OBGYNs. It's understanding your options and understanding how to have a productive conversation about how it can affect you in the long run. Because all these things that happen throughout labor can affect your pelvic health in postpartum. So that's why it's important. So again, I like this quote, the power of a birth plan isn't the actual plan, it's the process of becoming educated about all your options. So I think that's all I have. Yep. So I'm going to exit out of my screen so that Linda can share with everybody. You're muted.
Better.
That's helpful.
It happens, Okay, sorry. Okay, so let's start with bladder health. We're going to go over a little bit of bowel and bladder, some symptom management, urinary urgency, and talk a little bit about urinary and fecal incontinence. I broke it down in the sense of I'll go over bladder and all of the below, and then I'll go over bowel at the end. So first off, bladder health. If you guys look at the picture to the right, it is the one that Q had brought up earlier last week in regards to bladder filling. So healthy bladder function, it comes in 3 phases. So there's a storage phase where the bladder muscle, which is called the detrusor, is actually relaxed. It relaxes so it can fill. And the pelvic floor muscles, where people will talk about their kegels, those are actually semi-contracted to prevent leakage. So I tell people, think about what happens to a water balloon as we fill it with water. The balloon itself has to learn how to stretch in order to fill it at its capacity. And your pelvic floor is essentially the hand that's holding the balloon. As it gets heavier with fluid, the hand actually has to isometrically hold it up, but not really grip, because we all know if you grip it, it'll pop. So the transition phase is the filling phase. You actually have 3 signals, essentially. You could have more, but essentially we break it down into 3 different signals. First signal you get is essentially what we call the first sensation to void. You have about 5 to 7 ounces in the bladder, and it's just kind of the bladder telling you, hey, think about it. If you are doing something, are busy, don't have a restroom, don't need to go, then we kind of delay. And when that happens, you know, some time goes by, whether it's 5 minutes, 10 minutes, an hour or 2, you get a desire to void. That is our second knock on the door, if you will. You get about 6 to 10 ounces in the bladder at that point. And again, that's just the bladder telling the brain, hey, think about it. I'm getting heavy. I'm kind of filling. Where is the restroom? Maybe in the next half hour, 20 minutes. We make those decisions in a normal, healthy situation where we go, okay, well, it's 10 minutes till home. There's no traffic. I can just wait. Last signal, the third signal, is that strong desire to void. So it's anywhere from 11 to 18 ounces. These numbers are slightly arbitrary. However, thinking about that one time you're in the restroom line, you're fine at the end of the line, and you wait, you get to the front of the line, and all of a sudden it's kind of there. You kind of need to have the, what we call the P dance, the wiggle, the wobble, and kind of waddle your way to the restroom. So those are your 3 signals that the bladder gives the brain. And the last phase is emptying. You get into the restroom and you shut the door, you pull your pants down. When we sit down to void, your bladder is actually contracting. It's actually a reverse role. The bladder contracts to squeeze out all the urine, and your pelvic floor actually is supposed to relax to allow the emptying. It kind of goes back to it's going to go back to what Q will talk about next week in regards to pushing. So bladder habits. So the do's and the don'ts of bladder. So what you want to do, you want to maintain good fluid intake throughout the day. You don't want to front load. So a lot of people will think about, okay, well, if I need 60 ounces in a day, then I will have 60 ounces at 8 a.m. or between 8 a.m. and 9 a.m. and then nothing for the rest of the day. We're consistently filling and metabolizing, so making sure that you are very hydrated throughout the day is very important. Limiting your bladder irritants. So bladder irritants, some common ones are high caffeine intake, high alcohol intake, citrus, spicy foods. These are just things that irritate the bladder lining. And when it's in the bladder just kind of goes, don't like it, get it out. And that's how we get a lot more frequency, urgency, and things like that. Avoid and minimize constipation. Constipation, it goes hand in hand with urinary symptoms, and we'll kind of talk about that in a little bit. And then practicing pelvic floor strengthening and relaxation. Those, I don't think we hear the last word enough. We always hear about, oh, do your Kegels, get strong, make sure that's how you don't leak or whatever it is. However, we also need to learn what we call in clinic reverse Kegels, because if you don't know how to let go, then we also have a problem. And then allowing adequate time to fully empty in the restroom. This is a fun one. I think it relates to all of our postpartum moms, all of our working moms, all of anybody and everybody that's in a rush. Maybe not now because everybody's home because of this quarantine, or I guess if you have a couple kids home and they're fighting and you need to use the restroom, it's a really difficult time. But again, making sure you spend that extra 30, 45 seconds in the restroom to fully empty your bladder so it decreases your need to go back. Some of the don'ts we kind of talked about, don't drink water all at once, avoid ignoring the urge. That's another really big one. Depending on the profession, people call it, doctor's bladder, nurse's bladder, whatever it is. I guess we can call it PT's bladder too. But when you are on a schedule and are not able to use the restroom when nature calls, I'm sure we all do that. And at some point where it's just like, need to go, but I think I can wait, or need to go, but I have this patient, or whatever it is, I just need to get through X amount of time. And X amount of time just kind of turns into too long. When we start to do that dance to the restroom, avoid just in case voiding. So when we do this, it is when you're kind of like, oh, I'm about to leave the house, let me use the restroom. Or I just went 5 minutes ago, but I am about to leave the house again, so let me use it again. Every time you leave a facility that has a restroom that you're comfortable in, but even if you don't need to use the restroom, you do anyway, the just in case. Avoid hovering. This one's a little tough with sanitation purposes, but that is why we have those seat covers. But hovering also changes the mechanics of the pelvic floor and how much it's actually working and allowing the bladder to release. So that is also a reason why we kind of try not to hover. And then we talked about rushing and straining. So urinary urgency. So really quick at the bottom of the list, you'll see normal patterns and normal volumes. Normal voiding patterns for the day, this is in a 24-hour day, is 5 to 8 times a day. Generally about, if you did break it down, 3 to 4 hours. And in the middle of the night, we're probably going 0 to 1 time a night. And the last bullet point that says 8 to 10 seconds per void, I think it depends on how fast people count. Usually thinking 1 Mississippi, 2 Mississippis, but it depends on, it's relative. However, we're looking to empty at least half the bladder. So if you look on the right of the screen, the normal bladder volumes, max capacity is anywhere from 15 to 19 ounces. So I tell people, think about a Crystal Geyser or an Arrowhead water bottle that you buy from the store. That's about 16 ounces. Your bladder can hold that. Okay, so normal output, if you look at that second bullet point, is 10 to 15. So roughly-ish half is what we're looking for normal voiding. Post-void residual is actually what is left in the bladder after we fully empty in a non-rush circumstance. It's less than 2 ounces. And so that's actually something that the urologist or the doctor can test in the clinic if that is something that you need to be going in for. Urinary urgency kind of comes on very suddenly. There is a strong, like you can sit here right now, listen to me, and all of a sudden there's a strong urge to use the restroom. And there's a couple reasons. We talked about the bladder irritants. Okay, that can be a really big thing. Infections, so UTI, yeast infections. If anybody's ever had them, you know that there's this really strong urge. You go to the restroom and it's maybe a trickle if you're lucky. But also urinary urgency comes on with habits. So if we waited too long and we're used to that, and all of a sudden it comes on and it's strong because we've delayed, and we've desensitized ourselves to the delays. And all of a sudden you get to the point where the bladder's really full and it's just kind of like there's no more delaying. So you have that urgency, or it's the detrusor muscle, your bladder muscle, contracting too soon or too early, causing that increased pressure in the bladder, having that sensation to need to use the restroom. So urinary incontinence, what is it? So I looked this up with the Mayo Clinic. It's any accidental or involuntary loss of control of the bladder. And when I say loss of control, I don't mean completely. I tell my patients any little drop that you did not want to leave the body, if that ever happened, we're deeming it under that umbrella. Okay, so this little map down here, 33 million people suffer from urinary incontinence in the United States. And it's not just women, it's higher in women, but men also experience it. 1 in 14 men, 1 in 3 women. So how many people? Oh, I can't see it, sorry. I was gonna take a poll, but depending on how many people we have in here, look left, look right on your screen, someone in here probably has it, okay? So looking at that, and a lot of people think, oh, it only happens to geriatric patients, people that are older, blah, 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 blah. It actually is a pretty high percentage in women younger than 65, women or men younger than 65. It's, again, higher prevalence in people that are older. However, it is still prominent. So let's look at common causes of urinary incontinence. Pregnancy and childbirth, very high causes. Vaginal birth versus a C-section, there's a 30% higher increased risk or cause of incontinence due to the fact that, like you mentioned, the stretching of the vaginal region, all the pressure that has been there. Pregnancy, because of the increased pressure and weight, weakens the pelvic floor. Childbirth, there could be trauma, whether it is an episiotomy, a tear, a prolapse, which is what we'll talk about next week, and some nerve damage and all of that happens down in the pelvic region. Menopause is also a common cause, and they think it is more of the change in hormone, the decrease in hormone that makes the urethra a little bit weaker, which then leads to a little bit of leakage due to the fact that it can't close everything completely. Surgical procedures, so looking at C-sections, hysterectomies, any lower abdominal, pelvic, sometimes even GI type surgeries, because they're cutting through that many layers. There may be some nerve damage, there may be some muscle damage, so all of those things play a very integral role in how we manage our bladder. In men, enlarged prostates, prostate cancer, those are very big as well, because if you think about a funnel, the prostate is actually at the base of that funnel and acts like a little stopper. So if it's enlarged, then it's constricting on the urethra. If there has been any tumors or cancers in that region, again, constriction or any type of radiation, chemo, that affects that area as well. Neurological disorders, patients who have traumatic brain injury, strokes that may involve that region of the spine, as well as spinal cord injury. And then bladder irritants, we had talked about it earlier. You know, your common ones are alcohol, caffeine, citrus, spicy, medications is a really big one as well. So risk factors. So gender is a really big one, as you guys saw in the last slide. Higher risk factor for women than men. Age is a factor, but it's lower on the list. Just again, as we get older, there is a little bit of weakness, but also looking at the lifestyle we led leading up to it. Weight is a big one due to the excess pressure that's on the bladder. Smoking, tobacco has a high correlation to urinary incontinence. And then we'll talk about lifestyle and diet. So types of incontinence. There are 6 types in total, but then I'm going to show you the common 4. So from left to right, you'll see stress incontinence. Stress is more of increased abdominal pressure. So anything we talk about like laughing, coughing, sneezing, anything that increases pressure that causes the bladder to kind of have to take up impact. Urge incontinence is the involuntary contraction of the bladder. So again, we talked about that coordination piece of bladder and pelvic floor. Overflow incontinence usually happens due to the fact that there's some constriction at the urethra, which means that the bladder is filling normally, but it's getting to capacity and it's running out of space. So generally speaking, it could also be a pelvic floor dysfunction where there is not enough relaxation that happens to allow things to come out. And then the last one to the right is the neurogenic incontinence, which is due to a nervous system issue or dysfunction. So, I went over them here. Stress urinary incontinence, loss of urine due to increased pressure in the abdominal cavity. Physical activity, exertion. So common ones are coughing, laughing, sneezing. I think after getting into this work, it's really funny that when you say like, oh, I laughed so hard I peed myself. It's a thing. So keep in mind. Urge urinary incontinence is a sudden irresistible urge to urinate, and you may have some leakage on the way to the bathroom. Or when you're in the bathroom, the pants don't come off fast enough or something of that nature. Mixed incontinence is a combination of urge and stress urinary incontinence. Overflow incontinence, like we talked about in the photo prior, it is just a trickle discharge of urine due to the fact that there's increased pressure in the bladder due to a restriction of some sort. Symptom management for healthy bladder habits. So hydration, 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 hydration. Drinking plenty of water, and I mean flat, boring, clear water, not carbonated, not sweetened, not any of the sort. The regular one that comes from the geyser. We want to aim for half your body weight in ounces. So I tell people that's what we do in the clinic, because 8 ounces for you and I versus 8 glasses for you and I versus 8 glasses for Shaquille O'Neal, very different, as well as an athlete who runs, the ultras. They're running 100 miles a day versus 2 versus something else. So those play a really integral role into how much water you should be drinking. Physical activity is a really big one. Adequate coordination and strength of pelvic floor. So this is a really big one that we talked about earlier. So contractions are what the Kegels are when you squeeze and make sure things don't come out. But then the relaxation piece is very important, because things also need to be let out when you are ready for it. So really quick, everybody sitting here, really quick, inhale, exhale. and squeeze your pelvic floor. Can you stop the flow of urine, and can you feel that? Or do you feel your butt cheeks working, right? And then when you relax it, do you feel it completely open, or does it feel like the same kind of sensation? So some things to just kind of think about. Lifestyle habits. So avoid pushing and rushing in the restroom when emptying. And also avoiding bladder irritants are two very big ones to start with. So next we'll move up to bowel health. So how does the bowel actually work? The digestive system breaks down and absorbs food and fluids that are consumed to make nutrients for the body, which kind of gives us the energy to do whatever we want to do. And it actually runs from mouth to anus. So esophagus, stomach, small intestine, large intestine, which can also be intermittently used as a colon, and then it gets to the rectum, and then it lets out at the anus. So food, depending on what you ate, how much you ate, and all of those things, it takes anywhere from 12 to 48 hours for food to travel from one end to the other. And normal bowel movements actually vary day to day and person to person. So looking at someone can go 3 times a day and that is their normal, versus every 3 days and that is their normal. And again, we're just looking for consistency. If you go from every 3 days to 3 times a day and you haven't done anything different, that may be something to think about, or vice versa. If you used to go 3 times a day or 1 time a day and you're now going every 3 days for no specific increased reason, such as pregnancy and stuff like that we'll talk about, something to probably think about and see if you can change or see the doctor for. So really quick, this is the Bristol stool scale. This helps us figure out where everybody is in their bowel movements. So really quick, everybody take a look at the screen and just kind of come up with a number that you most commonly register when you flush the toilet. Okay, so generally speaking, if you look on here, type 1 to type 3-ish is signs of constipation, right? They're hard, they're small, and they're lumpy. Okay, ideal is kind of from here to here. 3 and 4, where 4 is kind of the ideal golden rule of soft and smooth. They're still sausage-like. And then 5 through 7 gets softer as we go, and 7 is more liquid-based. So now you see why we have this, so people don't have to actually describe it to us. But thinking about what you eat as well as how hydrated you are puts you on the scale of 1 through 7, and just kind of see what your most common is. So constipation, signs of constipation, less than 3 bowel movements per week. If you have to really sit there and strain, if you're really pushing and sweating bullets, lumpy hard stool, if you feel like you're pooping pellets, some people tell me, sensation of incomplete emptying. You can sit there, really push, and you get a little bit out, and that's about it, but you still feel very bloated and uncomfortable. Okay, that may be a big sign. As well as sensation of blockage or obstruction in that low bowel region. So any increased pain in that lower left region. Lower left corner of the pelvis, I call it the poopy corner. So constipation, that's generally where you're gonna get a lot of discomfort if you touch it. So if you're rubbing your belly right now, lower left corner, okay, just right above the hip bone. So give that a rub, see how that feels. And then causes of constipation. So this is not an all-inclusive list, but most of the big ones that we see in clinic: irregular meals, skipping meals, not enough fiber, dehydration, types of medication, especially pain meds and stuff like that, will cause high constipation. Abuse of laxatives. So generally laxatives are used if you've kind of felt constipated and can't go and you want to try to loosen up the stool to get a bowel movement. But if it's repetitive use and the body's getting used to the need of an aid, then it will be backed up without it. So changes in life routine, pregnancy is a really big one, and travel, as well as aging. Sometimes aging is an interesting correlation just because the metabolism starts to slow, as well as the muscle linings start to weaken. So the peristalsis that happens in the intestines slow down a little bit. Also, ignoring urge to have a bowel movement. So having the urge and being like, I can't go, is also another thing. It affects the bladder like we talked about earlier, but it also will affect your bowels. Problems with GI function, colon or rectum. So if you have IBS, I guess if you don't have IBS, but if you have, well, sometimes, depending on what type of GI issues you have, constipation may be a cause. And then specific diseases, lack of physical activity. So my big thing for a lot of patients is motility. The more you move, the more things move inside you, okay, which kind of bring things into the rectum. So on the flip side, you have fecal incontinence. So type 1 Bristol stool scale was more of the hard, lumpy ones. This would be our type 7s more so. However, it doesn't necessarily always have to be. So fecal incontinence is the inability to control bowel movements, causing stool to leak unexpectedly from the rectum and the anus. Common causes: pelvic floor weakness due to any trauma, damage, or any of that sort. Nerve damage where the sensation is altered and you can't feel pressure or the need to use the restroom. Chronic constipation is also a really big one, because if you are very backed up or have obstruction in the bowel, then things are still moving, gravity's still working, but you might get something that comes out that you don't necessarily know. Diarrhea, if stool is on the wetter side, fluid is harder to control and close off. So there's that. Hemorrhoids. Hemorrhoids are internal or external, but when they're active and flared, they cause these little pockets that don't allow the anus to completely close. So when that happens, then you may or may not have a little bit of leakage in that. Loss of capacity in the rectum. So again, if there is any surgical procedure that someone had to have part of their rectum removed or something of that nature, then you'll get a little bit of leakage from there. So risk factors, again, age, gender, nerve damage. So neuropathy with patients who have multiple sclerosis or diabetes mellitus. Again, the sensation change is big. Dementia is a really big one due to the fact that the person is not aware that they need to use the restroom, or they forget. That's a really big one. And physical disability. So unable to get to the restroom in a timely manner because of a functional limitation. Okay, symptom management for healthy bowels kind of runs on the same list of bladder. So looking at hydration, making sure you drink plenty of water. Nutritious diet, so whole foods, adequate amount of fiber. Fiber is a really big one. Generally speaking, we're recommending 20 to 35 grams a day. That depends on the person. You also don't want to overdo the fiber because that could back you up. Eating meals regularly. So again, the body's really good at survival mode. If it doesn't get food in, it just kind of hoards it because it doesn't know when the next supply is coming. So making sure you're eating regularly and you're eating roughly around the same times. And chewing thoroughly. So don't scarf down your food and walk away. So making sure you chew and you're able to break it down and help with digestion to be more efficient. Physical activity for motility and coordination of pelvic floor. So looking at, again, right, if you have an urge and I need to walk from here to the restroom, my pelvic floor has to squeeze to not let anything out. But also when I do sit down, making sure that I'm able to relax enough to allow the sphincter to open and allow the contents to escape. And as well as lifestyle and habits. So sitting posture. A lot of people talk about the squatty potties. If you don't have a squatty potty, I tell people grab a yellow book. I guess they don't have those anymore. Shoe boxes. Shoe boxes are great. So making sure you stack them up and just make sure your knees are higher than your hips. It just changes the angle of the rectum and allows easier bowel movements. And avoid straining and pushing. Again, you shouldn't need to be sitting there to really, really push and strain and hold your breath and turn purple. If that is the case, that is something we can talk about. That is all I have for you.
All right.
There you go.
Let's see here. All right, everybody. All right, so I'm Sarah, and I will be going through pediatrics again. So today we'll be talking more so about how constipation and the bowel it goes with in the pediatric setting, and what we can do for our kiddos that are suffering from constipation and how we can help improve their regularity. And then at the end, I will be talking a little bit about what pelvic physical therapy looks like for children. So we just finished up a wonderful talk by Linda on bowel function. So I don't need to go through a whole bunch of it. I'm sure you guys understand how food gets from the mouth down to the rectum and the anus. But one part of it that I really want to point out is how the actual urge of a bowel movement comes on. is that as stool is collecting in the rectum starts to stretch, and those, oh, you lost my picture. My own picture, huh? That's probably, all right. Sorry about that. I just got a message that you guys lost my picture, but hopefully you can see my screen. And that's one of the most important things. Okay. All right, so sorry about that. So when stool is collecting in the rectum, it starts to stretch, and there's delicate nerve endings in this area that start to detect the presence of solid, liquid, or gas contents, which is why you tend to know what you have waiting for you. And your brain can then make the decision on whether or not you want to go to the bathroom right away, whether you need to defer it, whether you just need to pass gas, which wouldn't necessarily require going to the bathroom. And then you decide if defecation is actually convenient or not. And this is a big one for our kiddos because kids love to play. The last thing they want to have to do is to stop and have to go to use the restroom. So we'll be talking a little bit more about that, but that is a big decision point for our kiddos. So we really want to be teaching them to listen to their body and to not ignore these signals. So once you do sit down on the toilet, then your pelvic floor, just like with bladder function, your pelvic floor is going to relax. Pressure in the rectum is going to increase to push stool out. And then as soon as the stool exits and defecation is complete, then the pelvic floor is going to involuntarily contract again to help make sure that nothing is escaping. So you see on the right here, just another version of the Bristol stool scale. So this is showing us the different types of stool that an individual might have. So just like with adults, we're trying to aim for the type 3 or type 4, more sausage-like looking stool, and that's the same for kids. And we'll be talking later about how the type 1 and type 2 above can be signs of constipation. In terms of the frequency, obviously when children are infants, they are having a bowel movement a lot more often than an older child or an adult would. And so it just tends to decrease with age. By age 4, it tends to reach more of an adult frequency. So we're looking at about 4 to 9 times per week, just like with adults, you don't have to have a bowel movement every single day, but I would say with children, it's really good to be monitoring this with your kids, especially as they get older and they don't need your assistance in the bathroom anymore. It's still a good idea to have an understanding about how often your children go, because I find that a lot of parents don't always know. You should be able to defer a bowel movement by 15 minutes, but again, we really want to watch this with our kiddos because as soon as you defer a bowel movement, if you defer it too long, you're going to tend to lose the sensation, and then you're going to forget that you needed to go at all, and that's when something like constipation can rear its ugly head. So this is an infographic here that I found that I really like, but I will admit it is from the United Kingdom. It is not from the US, but I think that a lot of the stats are very similar to what you would expect in the United States. But just to point out a few important things is up here on the top left, 95% of children or childhood constipation is idiopathic, meaning that there is no rhyme or reason or physiological or anatomical problem that is causing the constipation. So a lot of times we don't know why it's occurring. On the bottom left here, up to 30% of children do experience constipation at some point. And I think that stat is pretty accurate. I want to say that it was about 29% more recently in the US, so not too far off. And toddlers definitely are very prone to constipation, and you're not going to necessarily know about it. And it really can happen across the age span, as we've been talking about. So constipation, on the right here is a picture of an x-ray, and this is what doctors will do if constipation is suspected. It's something called a KUB x-ray, and if you can see my pointer here, oops, click by accident, you can actually see this darker portion, this rainbow shape right here. That is actually constipation. That is stool that has backed up in this child's colon. And so this can be a great visual on whether or not a child is backed up. And so with constipation, it tends to get worse and not better. So if you suspect that your child is constipated, even if you suspect yourself that you're constipated, it's really not the kind of thing you just want to watch and wait to get better. You want to be proactive about trying to address it. And so with constipation, one of the reasons that it tends to get worse is because as the stool backs up, the large intestine's job is to draw out moisture. And so the longer stool sits in the large intestine, the drier it's going to get. And then the more that tends to back up, then you're going to get the colon and the rectum actually stretching out more because it's like a really bad traffic jam. Everything just keeps coming from behind, but there's nowhere for everybody to go. So everybody just starts gathering around, and that can lead to stretching of the colon and rectum, which also will lead to weakness of the muscles and the smooth muscles in this organ, as well as poor sensation. We talked about how that stress receptors, nerve endings in the rectum are telling us if we need to go. Well, if there's always something present, our body's going to tend to fade it out after a while. Similar to when we get dressed in the morning and we put our clothes on, we often can feel that we just put our clothes on, and we might still feel that our shirt is on us for the next few seconds. But as soon as your mind is off to something else, you forget. You don't think all day long about how my clothes are on. You don't feel that because your nervous system is very smart, and it helps to filter those kinds of things out. Well, just imagine in this area, if there's a constant stretch, and because there's a constant backlogging of stool, our body's going to tend to fade out that sensation. And so even though it's present, you might not always feel it. And then when it's time for a bowel movement, when a child or a person tries to have a bowel movement, they can be very painful. It can develop in fissures, which are abrasions on the inside of the anal canal. With straining, you can develop hemorrhoids. You're going to get abdominal pain, bloating, gas, and then we'll talk about how fecal incontinence and something called encopresis occurs in children. So not to drill it in again, because I know Linda did a great job at talking about a lot of the causes, but just talking about causes of constipation in the pediatric population. Diet and hydration is a huge one still. We really want to make sure that the kids are getting a good amount of water and they're getting a well-balanced diet. Stool withholding. So stool withholding is when somebody has is not going for a bowel movement, even though they might have a sensation for it. And that can occur, especially in kids with pain. Maybe they remember a very painful bowel movement, and so they're afraid of experiencing that pain again. So they hold their stool thinking that it's going to help prevent that pain from happening again. They might be ignoring the sensation. Like I mentioned, kids that they love to play, they might not want to have to stop what they're doing, so they ignore it. The sensation goes away, and then they don't think about it till who knows how long. There can also be emotional reasons to think about even our older children. Maybe they don't want to have a bowel movement at school. Maybe they're embarrassed to. Or not that this is on an emotional level, but maybe they're more fearful about a toilet being unclean. They don't want to sit down on it and have a bowel movement. So They might be withholding stool for those reasons. Poor physical activity, again, just like Linda talked about, that's a big one. So think about the kids that just sit and play video games all day. They are not moving their body, and gravity is not helping stool to get dropped down and to move along in the large intestine. Changes in routine, like travel, is a really big one. But I mean, think about when moving, or parents bring home a new baby, or they start a new school, or they start school to begin with. A lot of these routines can really affect a child's bowel movements. Poor muscle coordination, this is more meaning with the pelvic floor. So there are instances when the pelvic floor muscles do not relax, and that makes bowel movements very difficult to pass. And so that can also cause constipation. Underlying medical conditions, a lot of kids with low muscle tone, for example, kids with Down syndrome, it is just a genetic factor in their condition that they have low muscle tone, and that is going to be included in the smooth muscle too. So their large intestine, which has the muscles that's going to help to push stool material, waste material through, they're not going to be quite as strong and going to be contracting in the same way. So their gut tends to be a little slower. Any kind of illness, there are nerve damage instances that can create constipation, and then medications that they might be on can be a big one. And then at the end, the unknown is that there's lots of kids we just have no idea why they're getting constipated, and that is a large portion of it. The signs of constipation, the stool withholding, crying or appearing in pain with defecation, loss of stool in their underwear. If they're not going at least 4 times a week, or even if they are going several times a day, if they're going more than 3 times a day, it could be that they are just so backed up that things are just are needing to come out more frequently. That there's just that long traffic jam that things need to start moving through, and so their frequency of defecation can go up. They might have excessive gas, or even foul smelling gas or stool. Obviously, most gas and stool is not a pleasant smell anyway, but you know when something just doesn't smell right. Hard stool or loose stool, and we'll talk about that in a minute. If they're complaining that their tummy hurts or their bottom hurts, if you notice that their tummy is distended, if they've lost their appetite, have poor energy, they're just irritable, because when we don't feel good, we tend not to be happy, and they can maybe throw a few more tantrums than normally, and that can be a big problem. Urinary problems. So I talked a lot last week about incontinence in children, or urinary incontinence. And so constipation, really big link with that. And with frequent urinary tract infections in kids, it's often because they are constipated. So fecal soiling or encopresis is when when a child is uncontrollably losing some stool material into their underwear when it's not wanted. And so if you look at these 3 lovely colons here, on the left side, this is more normal. And so stool's collecting, you can see that it's pretty narrow, and there's just a small amount here. But then if you look at the middle one and the right one, a lot more stool is collecting. So what happens is you see that a lot of this stool looks almost like that type 1 rabbit pellet looking stool. And what happens is it stretches, like I mentioned earlier, it tends to stretch out the rectum and the colon. So this is what you would see on that x-ray. And now that these small pellets are all backed up here, the only thing that's really going to be coming through is more liquid stool. So just think about if you had a jar full of pebbles and you poured water on top, how quickly the water would be able to flow around those pebbles. But then the more solid masses just build up on top. And so in this case, a child will uncontrollably lose this liquid because one, it's stretched out, and one, they don't have sensation that it's there anymore because it's always there. So their body has phased it out. And so a child will have a few drops of what appears to be a brown liquid. It can also be just a smearing of some pasty-like substance, or it could even just be a small little pebble that has worked its way out. The children are often unaware of this accident, and that's really important to understand. And I put a note here, it's really important to not punish and not embarrass the child because it happened, because most of the time they do not know it's happened, and it is not their fault that it has happened. So it is not a behavioral outburst. They're not trying to do it to make anybody angry, and it's just an unfortunate accident that tends to happen. If it does happen occasionally or frequently with your child, it would be important to get them to see a doctor to look into constipation. So, and I didn't mention this last week with the bladder as well, is that urinary accidents often also don't happen because the child is doing it on purpose. It's important to work with the child to try to figure out what's going on and how to stop it versus get angry at the child or punish the child because it's happening. A lot of times there's something bigger going on that the child cannot help. So some simple strategies. Now these are going to be if you do suspect constipation with your child, but I think a lot of these are also just really important habits and routines to develop with your child as from potty training on. I think the earlier you start these things, the easier it is to ingrain it in them. So the first one being drink plenty of water. Make sure they're getting that 6 to 8 glasses of water a day. And as we talked last week, you could use half of a person's body weight in pounds, and that would be how many ounces of clear fluid they should have. Make sure they have a well-balanced diet. So fiber is a big one, but as Linda also mentioned, too much fiber can make you blocked up and constipated as well. A good rule of thumb is to take a child's age and add 5 to that, and that's roughly how many grams of fiber you should be aiming in your child's diet a day. You really want to limit this really starchy food, the real processed food, because that tends to be more constipating. Dairy can be constipating, and it's really important that they chew their food well. I know I watch my own kids and I see a large mass of food go in their mouth. Maybe they chew it 2 or 3 times and down the throat it goes. And so it's really important to be encouraging with your children that they chew their food well, because that is going to help the digestive system in the long run. Exercise routinely, also a big important thing. They've got to be moving around, and that is going to help to move things through their digestive system. And then sitting on the toilet at the same time. I think that children from potty training on, if they get used to having a routine bowel movement or having some time where they just sit and relax on the toilet, can be a really good habit to get into. And it's best to try to do it about the same time every day. After a meal tends to be best, and morning tends to be best. That's when our digestive system tends to be the most active, and when most people tend to find that they have the best bowel movement. Posture is a big one, which I'm going to talk about toilet posture in a second. There's also a bowel massage that you can do, which I will be showing hopefully a small video of at next week's webinar. If you look on the right here, the toileting posture. This is an ideal toileting posture. Linda talked about it. Get a little stool, try to get the knees higher than the hips, a slight bend forward in the trunk, but it's important to keep the back straight and don't just fall over and curve your back. Prop yourself up on with elbows. So with children, especially once they've graduated from a training toilet to a training potty to the actual toilet, it's really important to get their feet supported. Don't let their feet just dangle. They need to be able to relax, and so having a proper, even smaller toilet seat for them and proper foot support is really important for them. And then encourage ways to relax on the toilet. The toilet is not about trying to rush through it. Just like with urinating, we need to encourage children to take their time when sitting on the toilet to have a bowel movement and make sure that they get everything and that they're really relaxing. It's important to relax the stomach, to relax the bottom. And ways that you can do this to help children is things like deep breathing, gentle songs with them. Blowing bubbles is a great way to get them to relax their pelvic floor, and even blowing a pinwheel. So with small children that are learning how to sit on the potty, or if your child is experiencing constipation and you want to encourage more relaxation on the toilet, have some bubbles and a pinwheel or something that you can do for your child while they're in the toilet to keep them engaged and to help them understand ways to relax. If your child needs extra help, if the general recommendations that we just went over do not help, they should go in to see their pediatrician. And like I mentioned earlier, they might do the x-ray called a KUB to rule in constipation. They're likely going to educate you on diet and supplements for the child to help with regularity. They might be recommending laxatives or medications in general, which might include laxatives, stool softeners. A clean out is when you use a high dose of laxatives to over a few days to encourage full clean out. It's similar to what you do after, or before a colonoscopy, is that you just want everything cleaned out, and then they often will keep the child on what's called a maintenance dose of a laxative, so that they are clearing out routinely. They might also recommend suppositories or enemas. And if a pediatrician feels it necessary, they might send the child to a pediatric gastroenterologist to help with more types of diagnostics. This might include something called anorectal manometry, which helps to understand the function of the anus and the sphincter muscles, and how well a child is able to feel sensation. So they actually insert a balloon and they fill it up, and they can see at what degree of filling a child can identify. And this is also something they do with adults when the child is able to identify that there is something there and they feel like they need to have a bowel movement. That can be really valuable information so that we know what kind of sensation the child has. And then there's also biofeedback, which is something we often do in physical therapy, but some GI doctors' offices will also do it in-house. If therapy is indicated for these children, they might be sent to a specific pelvic PT. There's also occupational therapists who do specialize in pelvic health too. So they might be sent to an OT. Traditional pediatric PT and OT can be very valuable. A lot of that is because we do a lot of core strengthening and sensory integration. So children who just have difficulty regulating their sensory system, there's lots of interventions that can be done in traditional PT and OT to help with this. Speech therapy can be helpful if the child's having difficulty communicating about a bowel movement. And then in the case of autistic children, ABA might be helpful to help make goals about the act of getting to the bathroom and identifying when they need to go. Schools, it's really important to be talking to your children's teachers and the school nurse about what's going on with your child if you are suspecting constipation or really even anything that's going on bowel or bladder wise, so that the school and the teacher understands that this child needs to be able to go to the bathroom whenever they need to go without any kind of repercussion. It's really important, and there are ways. It's important to be talking to therapists and doctors about ways to work this with your teachers. If it's necessary and your child has an IEP, you might want to make sure that goals are added to assist with toileting at school, or even a simple 504 plan. So if your child does end up in pelvic physical therapy, what are we going to do? A lot of people think, wow, well, I know what you do with an adult, but what on earth are you going to do with a child who doesn't understand everything? So if a child walks into the office, I will do an extensive parent and patient interview depending on the age of the child, but I do want to hear the child's view about what's going on. So I know how to cater our interventions to that child and to the family. And it will likely involve an external exam of the perineum. So I'm looking at, in the case of constipation, I'm looking at the function of the anal opening. I'm looking to see what does it look like at rest. There might be some palpation involved. If I do feel that it's necessary to feel on the outside of a patient's pelvis, I will ask not only the parent or caregiver, I'm going to ask the patient too. I don't care if they're 3 or 4 years old. If they say, no, I don't want you to touch my bottom, I am not touching their bottom, no matter what the parent says. So usually if they say no the first visit, after a few visits with me, we develop a rapport. They might feel a little more comfortable as long as their parents are also comfortable with that. But it's really important to get consent from both parties. Internal exams are extremely rare. It is not something to be expected, but there's very few cases where that might be necessary, and that's going to take a lot of thought on the therapist and the parent and the individual. To decide on that. There's going to be an inspection of the abdomen, so looking to see, does the tummy look distended? Does it feel like they're constipated? Can I feel stool backing up in the area of the large intestine? I might even use a stethoscope to listen for bowel sounds. Other gross motor assessments, I like to see how a kid moves. Are they strong? Are they meeting their milestones? I am going to look for diastasis recti. Children have it too, just as men have it, as well as we've learned that women have it. It's, with children who are constipated, they will often have a diastasis, which is that little bulge that forms at the midline of their abdomen. So I want to look for that with children. I want to see what kind of flexibility they have and what kind of strength and coordination they have. It's not just about their pelvic floor. It can be about how their hip strength is and what kind of postures they have. And then I will at the examination, I will also give a bladder diary, or excuse me, it should be a bladder or a bowel diary to the family, so we can start to see what the patterns are with the patient. In terms of treatment, initially a pelvic physical therapy session with a kid is going to be a lot of family education on their fluid intake, their diet, ways to prevent constipation, similar to what I just talked about on the previous slide. Toileting posture, the bowel massage technique that we'll learn next week. If bladder is the concern, how best ways to empty the bladder. If bladder retraining, timed voiding, or bedwetting training needs to occur. We may decide to do pelvic floor coordination exercises, and this is where I said before, I don't really love suggesting that kids do Kegling just for the sake of trying to strengthen them. I'd rather it be done under the supervision of a medical professional, because children are a lot harder to read if they're why they might need it and what is going on. So I think it's important that you get an opinion before asking your child to do Kegels. And it's really important for kids to understand how to contract and how to relax. So we might utilize biofeedback, or it's fun for kids. They often like that it's almost like playing a video game where sensors are placed on the external pelvic floor, and it's hooked up to a computer, and you can either watch a graph, or we have animations of a rose opening and closing, and what the computer is reading is when the pelvic floor is contracting and relaxing, and the outcome is what's occurring on the screen. So it can be fun for kids to learn how to contract these muscles using the biofeedback program. We do a lot of breathing exercises and a lot of core function exercises. And these are things that we will also be going over next week. I will be hopefully showing some videos on some of my favorite exercises for breathing, the bowel massage, and my favorite core exercises for kiddos that will also be really helpful for children with pelvic floor dysfunction. So I hope to see you all next week.